Now for some considerations regarding outcome ascertainment. And for this presentation, I have to give credit to a previous PhD student of mine, Maya Helfrich, for having prepared some of this. When we are doing epidemiological studies, and including pharmacoepi, we are looking at a wide variety of outcome events. It might be mortality or suicide attempts or myocardial infarction or procedures or initiation, discontinuation or switching of a given drug. And across all these outcome events, we want to discuss how to measure it. So typically we will have some sort of outcome such as a disease or surgery or initiation or biochemical change, and we have a proxy. That is, the disease is proxied by a diagnosis, the surgery by a procedure code, treatment by a prescription fill, biochemical change by a lab value or lab code. And of course the question is then, what is the validity of the proxies that we are using? This is a question of, will this proxy classify those with the outcome as having the outcome? And of course also those that doesn't have the outcome, will they not have this outcome proxy? Are we sorting the outcomes into the right boxes? And in the question of, is a given proxy valid, we need to decide how to measure or assess this. So let's consider myocardial infarction. Myocardial infarction would typically be proxied by a diagnosis, for instance, an ICD-10 code of I21. If I raise the question, is this proxy valid? How will I test this? Typically, what is done is a comparison of the list of data that we have in the registries to some sort of manual assessment of chart data. And the chart version, including, for instance, the ECG or medical records, would be considered the golden standard to which we will compare our registry data. For this cardiovascular outcome, I have been looking into this study by Jens Sundbøl and colleagues, looking at cardiovascular outcomes and the validity of these outcomes in the Danish setting. And they have done exactly that. They identified 99 patients with the first ever I21 code. They looked into the medical records and decided that among the 99 individuals with a code, 96 actually had a verified MI event. So the question is, of course, is this then valid? So we will, for this purpose, design this 2x2 matrix. That is, do you have the code or not, or the proxy or not? And did you in fact have the disease or not? If you have both, you are a true positive. If you have neither, you are a true negative. But if you have the code or the proxy, but didn't have the disease, you are a false positive. Whereas if you have the disease but no code, you are a false negative. Typically, we will then estimate the positive predictive value, that is likelihood of having the disease given proxy. So if you have a code, what's the likelihood you're then having the actual disease? We can also talk about the negative predictive value, that is, given you don't have a code, what's the likelihood you don't have the disease? We have the sensitivity, completeness, that is the proportion of those with the disease that have a given registration, and the specificity, the proportion of those with no disease having no registration. Very many people, myself absolutely included, find it very difficult to remember the distinction between these four different things. In particular, the word specificity is quite often used incorrectly. So we have the positive predictive value, the negative, the sensitivity, and the specificity as defined here. So what are these particular values? Well, in the example just shown on myocardial infarction, we have 96 out of 99. That is the direct estimate of the positive predictive value. We took 99 with the registration and found that 96 of them had the actual disease. In most cases, even in the face of an available validation study of the proxy, we will have no assessment of the negative predictive value, and here we see no assessment of sensitivity and no assessment of specificity. However, in most cases, unless it's a very common disease, we can realistically say that the negative predictive value is, if not 100%, then it is very close to it. And the same thing for specificity. That is, with them, the number of people with no registration likely there is no actual disease going on, because the vast majority of individuals don't have the disease. However, the sensitivity is typically an interesting proportion that we don't really have. That is, if we could see all those with a disease, how many actually would have been registered as such. This is very difficult to assess, because in the positive predictive value, we can identify the individuals we want to look at from the registry data, whereas in the sensitivity, if we are to assess that, we would have to be able to address everyone to see whether they had, in fact, in this case, a myocardial infarction. So the perfect proxy is a proxy that will always represent an outcome, that is a PPV of 100%. And of course, it should be an outcome that will always trigger a proxy. So every person with this disease will actually be coded as such, corresponding to a sensitivity of 100%. But as said, validation studies often only address the positive predictive value. So let's assume we have such a near perfect proxy. This would correspond to high PPV, high sensitivity. So those with the outcome, those with the proxy, they are almost completely overlapping. This could, for instance, be cancer. The vast majority of those with the disease will get their diagnosis, and if coded with the diagnosis, it's most likely also a true disease, because we, for instance, could require histological confirmation. We'll also consider the situation in which we have a high PPV but a low sensitivity. It could, for instance, be having a hospital diagnosis of obesity. This is not something that is typically coded. However, if you have a hospital diagnosis with obesity, you are most likely to actually be obese, whereas we cannot necessarily rule out obesity in the absence of a code. The opposite pattern here, that is low positive predictive value but high sensitivity. It could, for instance, be the gastroscopy as a proxy for intestinal bleeding. The majority of those with an intestinal bleeding will have had a gastroscopy performed. However, there's also quite a lot of people with no ultimately confirmed intestinal bleeding that will undergo such a procedure. So this will most likely capture everyone, but it will also capture someone that doesn't have the diagnosis of interest. As argued in this paper by Snevers and Avon, generally speaking in epidemiology, we prefer having a high PPV over a high sensitivity. So that is, we most often want to prioritize having the registered outcomes being in fact valid over including everyone, but then also including less valid outcomes or invalid outcomes. The validity of outcomes might depend on different things, and for among other things, whether this is the first ever occurrence of something or a subsequent occurrence. In most cases, we have a higher positive predictive value of the first coding, because later events might not be new events. It might be, for instance, follow-up visits coded with the initial disease without actually a new event having happened. But this, of course, will depend heavily on the diagnosis in question. Here, sticking to the myocardial infarction example, we saw that there is a 96 out of 99 for the first time MI. It's slightly lower for non-STEMI events than STEMI events, and for recurrence, another 100 patients assessed, it's only 88, because only 88 out of 100 subsequent MIs, so non-first MIs, were in fact MI confirmed. Again, this depends heavily on the specific diagnosis in question, but as a general rule of thumb, we tend to rely more on the first diagnosis. So suboptimal validity, what does that mean? Well, that means typically we have some sort of misclassification, and this ties back to the pharmacology or exposure ascertainment discussion. What is the height difference between men and women? If we misclassify, be it exposure or outcomes, we generally speaking will sort of dilute differences observed in our study, typically meaning that we see a bias towards the null. So misclassification of outcome status is a type of information bias. We could see a low PPV. Those without the outcome are classified as having the outcome even though they don't. Or we might see a low sensitivity where those with the outcome are classified as not having the outcome. As long as validity does not depend on exposure status, that is, as long as the validity of the outcome is not correlated to whether you're exposed or not, this misclassification will be considered non-differential and in most cases biased towards unity, no difference, because it's making the groups appear more alike. Okay, how to address this? How to increase validity? Well, you could use algorithms to define your outcomes instead of relying on a single code. You could, of course, validate. You could stick to codes with high PPV and let go of other outcomes. You could restrict to incident outcomes or primary diagnosis or diagnosis only established at specialized departments. And most importantly, I think, consider doing sensitivity analysis in which you apply some of these considerations. As an example of an algorithm, this is a paper identifying patients with myasthenia in registries. And there's two different types of treatment, and there's also the diagnosis. And in terms of this, they decided only looking at diagnosis that actually had a fairly low PPV. Looking only at treatment that could also be used for other diseases had a low PPV. But identifying patients that both had one diagnosis and one of the two types of treatment yielded a very high PPV of 93%. Such algorithms can be considered excluding or inclusive. Excluding algorithms to increase the PPV could be a matter of setting multiple requirements to count as one outcome. Inclusive algorithms, which increases sensitivity, could have different ways to get to you being classified as having the outcome without meeting multiple requirements. An excluding algorithm could, for instance, be saying you only have a DVT diagnosis if you have the diagnosis and you initiate treatment with oral anticoagulants, or heparin, I guess, so anticoagulant therapy. So you are required to have both, which will increase the PPV. Or you could, in an inclusive algorithm, say we consider you as having diabetes if you either have a hospital diagnosis or you use an anti-diabetic drug. In deciding what outcomes or proxies or definitions to use, please consider involving a clinician. This is one clinician called Erik, whom I rely on for some of our studies. And it's quite important to include someone that has some understanding of the epi game and the coding practices, but more importantly, someone that is actually actively working as a clinician and knows the current coding practices in the system that you are using data from. So they can tell you of coding practices, differences, and also, of course, differences in patients, whether you are in fact capturing the patients or outcomes you would like to capture. As a final recommendation, please be aware of pseudo-clinicians, people with a medical background saying, oh, I know how this is handled, that aren't working in the current system because current coding practices change over time and so does patient composition. So be aware of pseudo-clinicians and make sure you involve someone that knows what is happening in the healthcare system currently. Validation is also a way of actually improving the quality. And sometimes this is considered much too time-consuming, and in many cases it is. It might also not be possible through ethical legal requirements not being fulfilled to perform individual level assessment of validity. However, in some cases it is actually possible, and sometimes it doesn't have to take as long as you would imagine. This is a paper by Jesper Halles published in the BMJ almost 2 decades ago. And here they identified those that might have upper gastrointestinal bleeding by the diagnosis code, and then they looked into those patients' medical records to identify those with an actual verified upper gastrointestinal bleeding. And while we are talking manual validation of thousands of cases, once you have established the requirements, legal requirements to assess this, they ended up being able to validate thousands of outcomes through only a few days of work, because it is only a matter of checking this and that, whether there is a confirmed gastroscopy, etc. And having more valid outcomes in this context, upper gastrointestinal bleeds, leads to much stronger data materials, because you remove a lot of noise from your study, which allows you to perform analysis with typically stronger risk estimates in case there is a causal association, because you are addressing the actual outcomes and not a mixture of outcomes and suspected outcomes. Identifying the literature on validation is typically an endeavor in its own right. In the Danish context, there is this monumental paper by Morten Schmidt and colleagues that are summarizing all of the, at this point in time, available validation studies performed across very many different outcomes in the Danish patient registry. And it's my understanding there's a new paper on its way with an update to this. As hopefully you are able to find something similar in your situation or your setting. So, just to wrap it up, the final considerations: what is most important? Well, this might differ across the study question that you are asking. You will have to decide whether it's more important to you to identify all outcomes, high sensitivity, or to make sure the outcomes you have identified are correct, that is, having a high positive predictive value. Unless something very specific is going on, you should prioritize the PPV over sensitivity. This will yield you a more valid study.